Welcome to the Endo Kids Podcast, the podcast where we help families navigate the ups and downs and in-betweens of growing up healthy. I'm Dr. Rinku Mehra, the founder of Endo Kids Concierge and a pediatric endocrinologist, and my co-host is Dr. Lindsey Waldman, who is also a board-certified pediatric endocrinologist. We are here to break down the science of hormones, share real stories, and answer the questions parents wonder about the most. So whether you're worried about growth, puberty, thyroid, or just want to understand your child's development a little bit better, you're in the right place. We believe every family deserves answers, support, and a caring partner in their health journey. So grab a cup of coffee, get comfortable, and let's tackle this topic together today. This podcast is for educational purposes only and is not a substitute for medical advice. Please consult your child's healthcare provider for individualized care.
Hello, everyone, and welcome back to the Endo Kids Podcast. My name is Dr. Lindsey Waldman. I'm a pediatric endocrinologist, and today I am super lucky to be joined by a guest. This is Kelly Benson Vogt, and she is a speech pathologist, and she works with Pediatric Feeding and Speech Solutions, which is located in Leesburg, Virginia. Today, we're going to talk about issues regarding pediatrics and feeding, try to answer some questions, and learn some interesting things. So first of all, Kelly, thank you so much for joining us today. Let's start by learning a little bit about your background and what inspired you to go into this field.
Oh, thank you, Dr. Waldman, for having me. This is going to be a lot of fun, I think. This is a great pleasure. So I have been a speech pathologist for 28 years. And for the last 16 years, I have been in private practice, my own practice. And I've also been doing early intervention for 20 plus years as well. Prior to that, I worked in just a variety of settings, inpatient, outpatient, hospice, pretty much all of the different settings, schools. But yeah, I've been settled in my own private practice for the past 16 years.
And after working with all different ages, how did you decide pediatrics was the place for you?
Oh, when I was in graduate school, I actually picked the adult neurogenic tract. That's specialty.
Very different.
Tract. I thought that was what it was going to be. And then I don't know. I don't have a really great answer for that other than it just morphed. And I graduated, was working in the hospital system, inpatient and outpatient. I'm sure having kids of my own did something towards the pediatrics too, but it's not, I had a child with a specific disorder that led me there. It's just that I got a taste, if you will, for feeding, the specialty area of pediatric feeding. And I have loved it ever since. I absolutely love what I do. And yeah, every day.
That's perfect. And while we're on that topic, tell us a little bit about what a pediatric feeding therapist actually does. What does your day-to-day look like? Why do patients come to you?
So by training, I'm a speech and language pathologist. And so I see speech and language disorders as well. But particularly for the feeding aspect of where I've tried to specialize, I see kids anywhere from on the continuum of complex medical conditions, cerebral palsy, Down syndrome, trachs, vents, G-tubes, really rare, cool syndromes, all of that stuff, all the way down to really your typical picky eater that's going through toddlerhood. And so I get self-referrals just from folks finding me on different sites and groups and social media and such, to direct consults or referrals from physicians and a variety of specialists.
And since you mentioned the topic of picky eating, and that's certainly one that comes up quite a bit, I'm sure you get lots of questions about that. How do you differentiate the typical a picky eater with a true feeding disorder?
Great question. One that comes up a lot, because we know that in toddlerhood, there is, air quotes, phase of typical picky eating. However, in saying that, I don't think we should just always expect that and assume that either that's going to happen. But truly, as kids start to eat solids and eat more things. And then really, as they get into toddlerhood and start to develop a sense of their own and a sense of control and saying no and refusal and all of that good stuff that they're learning in toddlerhood, they get preferences and they tell us about it. And I think this is getting a little bit off the topic, but I'll get right back to your question. And during that phase, when that's happening, I really do think there are things that we can do as parents to either in that inadvertently might encourage that picky eating to go further down that road, but things that we can also do to mitigate that picky eating phase if it's happening with the child. So back to your question though. So the typical picky eater, what I think of is they may go on food jags. So a toddler that wants to eat nuggets or French fries every day, 3 times a day for a week or 2 weeks. That could be a typical phase we call a food jag. When it becomes more atypical is when they do that, they keep going through the different foods, the foods drop out because the kids eventually get really sick of that. The foods drop out. And typically, as parents, when we bring those foods back in after a short break, we reintroduce them. Typical picky eaters will reintroduce them back into their diet and they'll start eating them again. And we can just continue that nice rotation and continue to increase the variety of the diet gradually over time and with repeated exposures and things like that. When that doesn't happen, then we're turning more into problem feeders because those food jags, they look normal, they look typical, the foods drop out. But then when we go to reintroduce them back in, the child's not having it. And so over time, the diet just really continues to decrease and decrease in numbers of foods that they will accept. When the stress level at the dinner table is just there or high, or parents are dreading meal times, oh gosh, or what am I going to feed them? Or they become a short order cook, or Johnny's eating one meal and Susie's eating another meal and mom and dad are eating something else. Like those things and stress to me are problems. And those are things that we can change and we can help. Those don't have to happen or go on. And that might just be signs of typical picky eaters. But like I said, it can then develop into more problem feeding so really being in private practice, I have the luxury of kids don't have to be eligible for therapy to see me like in the school system or an early intervention program. So if the parent is coming to me and they are stressed, and I can guarantee you if the parent is stressed, the child is stressed also. And we just don't think of that a lot of times. We just see the child maybe throwing tantrums and not think about why they're stressed. And so really everyone feels this at meal times. And so it's really the quality of meal times. And if that's a problem, it's a problem and we can address it.
And
So
so
it can be as mild as that or as more severe as a kid who's not eating any food and he was completely G-tube fed.
And when you think of maybe the more typical picky eater, the phases that these kids go through, what are maybe your top 3 tips that you have for families surrounding that? How do you keep that stress level as low as possible? Do you have any, again, just quick tips for more of your typical picky eating?
Sure. As we're in assuming that, like you said, everything is typical with the child. There's no other
Exactly.
diagnosis that we're worried about. We're not worried about allergies or GI involvement. I think one of the most important things that we can do is family meal times. And when I say that, I don't mean even thinking of just very old-fashioned beaver cleaver kind of family meal times that we sit together and hold hands every evening and have a nice dinner. I understand life is not like that. That is not functional for many people. We have soccer practice, we have ballet, we have so many things going on. We have long work hours where each parent is not home during meal times. So family mealtime, though, can mean one meal a week together to me. It can mean with eating together with one parent. It can be defined very different for very different family schedules. But It's so important because there's a lot of research behind the benefits of family meal times, and it goes way beyond food. And it's just some really cool research about kids' development, their reading skills, numbers of getting involved in drugs. There's so much stuff that, and then just family meal times, as from a speech pathologist standpoint, that is such a great time. Of course, if everyone's not stressed and tantruming, it's a great time to just reflect on the day. Even if the child is really even not talking yet, and we have two parents sitting, they're modeling eating. They're modeling mealtime behaviors. They're modeling vocabulary for that child, even if they're not actively involved in a conversation. And then with toddlers and with school age kids, it's just it's a really nice time. We can ask about the day. We can just explore what's going on in their life. So there's just lots of benefits to it. And from a feeding therapy standpoint, if it's really hard if a child is not coming to the table and at least sitting for some kind of structured mealtime, it's really hard to introduce new foods and to work on that expansion. And again, that can be defined lots of different ways for different time periods and duration sitting at the table, because I am well aware that a lot of kids just are uncomfortable doing that and aren't able to sit at the table for long periods of time. So there's all kinds of things with that, how we can define that. But so they went long, but the short answer is family meal times and then exposure. I really think that's the name of the game. What we model as parents and caretakers, how we eat, the things that we eat. Ideally, we're eating foods from each food group, if that's the traditional diet that we're following. And just variety, different colors, different smells. Because if it's not on the table or if we're not offering it, there's no way they're going to try it. They're not going to ask, oh, hey, Mom, I saw that cabbage in the refrigerator. Could you get that out? I'm really curious about that. It's just not going to happen. So lots and lots of exposure. And then one of the last things, I think what happens oftentimes that we can avoid is a child may start getting picky, may only want their kind of familiar foods all the time. And then what happens, just even inadvertently, I think parents then stop offering the other foods because it's, I don't want to waste food. I don't want to waste my time. I know he's going to refuse it, so I'm just not going to offer it. And that's a big trap that we can fall into. And then, like I said, even just inadvertently that happens. And we're like, oh, wow, wait, I haven't put a carrot on his plate or on the table for 3 weeks. And so again, if we're not exposing them to it, they don't have practice with it.
Yes, that exposure is so important and also can be so frustrating as a parent. I certainly have had the experience of putting out the green leafy vegetables again and again. And at some point, you almost feel wasteful, right? That you're throwing them away. But like you said, the exposure is so important. How do you feel about getting kids grocery shopping, cooking with you? Do you feel as though those are important things as well?
Love it, and love it.
Perfect.
Absolutely.
Okay.
Because, and what you just said, I wanted to go back just for a second because you said about wasting it and you put it out again and again, and then nothing happens to it. It just sits on the table. And I completely agree. And I always tell parents, I don't want to waste food. And especially in these times or at any time, really, we just don't want to waste food. And a different way we can look at this, like you mentioned, green leafy vegetables, we can use one spinach leaf. That could be the exposure. And even if they don't eat it, so oftentimes when people come for therapy, it's like we've tried all these things, we've introduced, we've exposed, and they don't eat it. And where I come in is at different levels. Okay, in my world, in my mind, it's not they either eat it or they don't. So it's a success or a failure. If they don't eat the spinach leaf, it's a failure. I don't look at it like that at all. I look at it, okay, is he comfortable to touch it? Is he comfortable to smell it? Is he comfortable to rip the spinach leaf up? Things like that, and engage in the food. Because if a child won't engage in the food, or if they're scared to do that, they're probably not going to put it in their mouth. So really that gets also into a more therapeutic level, but these are things that parents can do every day too. in just thinking of really small amounts, one, to not waste it, but also not to overwhelm the child. Because a large amount of a food that you don't like on your plate can be quite overwhelming to kids. And then that can set them into the tantrum piece. So thinking of that way. And also, like you mentioned, going to the grocery store, helping prepare the food. I love all of that because data does show us that helps. That truly helps. And then one other thing in preparing and even setting the table, cleaning up the table, scraping the food off the plate. And then like with toddlers, and you can find something at every age for their involvement in helping. And it's like a chore. You can make it like that kids should have some little chores along the way too. But like the example of the spinach or the lettuce, like having them, even if they're not comfortable eating it yet, having them rip up the leaves to make or stirring something for you. There's all kinds of different things how we can get kids engaged in the kitchen.
I love that. What are your thoughts on, I usually say the word hiding vegetables and things, whether it's zucchini in a muffin or some extra veggies in the pasta sauce. What are your thoughts and theories on that?
I know that's can be a controversial thing among people. I know there was the cookbook of Seinfeld's wife, I think it was, or that whole thing. What is nutrition? And so I have kids, and this is more therapy level too, but I have kids that won't go near the vegetable. If the parent wants to do this and the parent says, I know I can get that pureed carrot in the spaghetti sauce, and we can get the carrot in the child's body that way, I'm fine with it. Now, there's a caveat to that because I'm okay with it for a while, but then I also, as soon as that child is eating it comfortably, and it's not a big deal, I want them to know it.
Yeah.
I want to hit these things head on. I don't want to always skirt around it because the problem with that is once they figure it out or find you out or see you hiding something or hear that you've done that, they will not trust you with the foods anymore. And so I've seen kids inspect every bite or every food because mom or dad or someone has tricked them into eating something, or they've hidden a pea under a noodle on the spoon. And then they took that bite and were so surprised by it. And that just threw them for a loop. So we need to be really careful to have trust, have the child be able to trust us that we're not tricking them. But I also, like you said, I'm fine with, quote, hiding some things to get it in. And if it helps to get the nutrition in, great. Then we're getting the nutrition in, but then we can address it like, hey, buddy, look at that. You ate a vegetable today. Did you even know how you had a vegetable? Guess what? You ate a carrot and it was in the sauce. It was hidden. And then make light of it and have it be a fun thing. But I want them to know, what they're eating.
And what about any thoughts on the usefulness of if you eat your vegetables, you can get dessert or more of something? What are your thoughts on that one?
Yeah, I think as parents and caregivers, we do that all the time. And not just with food, right? You clean up your room and you get some. I think it's just part of life, really. And so as long as it's some natural stuff, and again, as long as we're talking about the typical child or the typical picky eater, I think leveraging that is okay. When it becomes a problem is when people are coming to me and they have gone up the ladder and up the chain of things that they can dangle for the child and they're not doing it. Or the child will only eat something for a quarter. That's like, I had a therapist friend who was paying her child to eat her vegetables. She was like, Kelly, is that bad? And I was like, that's not ideal. Obviously, we all want kids to eat a healthy diet for intrinsic reasons, and they're intrinsically motivated, and they know it's healthy and all that jazz, which is great. But yes, sometimes we have to do those things. And I think as long as we are using it as we would in the other area of life, like to get them to clean up their room or to get them to put their clothes in the clothes basket or something. If it's just normal kind of behavioral techniques like that, fine. But if we see that we're having to do that more specifically with feeding, or that's the only way I can get them to eat a food or try a food, then I think we have to reevaluate that and look at there might be a little bit more of a problem here that needs to be addressed.
Perfect. So going on that, we've talked about more of the typical things we might see in some of our patients. What are some of the ways that the atypical feeding patterns might show for parents? So even thinking about maybe the younger ages, infants and toddlers, what would be almost some red flags or things that parents should watch for that might be more than just the typical pickiness?
Sure. If we're in infancy, things can go awry really early. And in infancy, and it's very stressful, of course, but things like bottle refusal or difficulty latching during nursing, fussiness during nursing, of course, a lot of gassiness, reflux. These things can be tied to structural issues, tongue ties. Everybody knows about that, I think, these days. But even just like feeding refusal, bottle refusal, or fussiness at mealtimes, that can be a sign and a signal to so many things. And we really need to stop and ask some questions about tolerance, about skill, the tolerance of the breast milk or tolerance of the formula. Do we need to look at that? Constipation, just constipation alone, I'm sure as a physician, can wreak havoc with feeding. Any kinds of, and I'm still thinking infants too, but this can go up through the ages. Any reactions, of course, like skin responses that we see after foods, allergies. So those are the things early on that some people still, I think it's scary because some people say, especially when moms are nursing and breastfeeding, if they're having some difficulty with feeding, I think a lot of times still it's frequent to say, oh, it's just your first baby, or it's supposed to hurt nursing, or it's you just muddle through it. And those are definitely, I would not give that advice. Those are definitely red flags that something is going on. Again, it should not be stressful. It should be a really nice bonding time between mom and a baby if they're nursing and dad if they're bottle feeding, just really bonding. And so if it's stressful, definitely that's a red flag.
Okay.
And then going up through the ages, really the same kinds of things, but constipation, skipping meals, gagging, vomiting. It's typical for kids, a gag here and there when they're starting a food or you introduce a new flavor on those first around 6 months or so when you're starting purees or solids or the bumpy, lumpy solids. A gag here and there is quite normal. But if it persists and doesn't go away, or if they're not able to transition to solids or the bumpy, lumpy foods, things like that's definitely a red flag. And then if we just jump a little bit older, I have school-age kids that don't eat the whole day while they're at school. And there are lots of reasons for that, and we have to dig. But I have kids, older kids that come in, and I'm starting to ask questions, and they're sitting on the couch beside their parent. And I am asking questions like, does food ever feel like it gets stuck in your throat or anywhere when you're eating? Or does food ever feel like it comes back up or like you vomit in your throat after eating? And more often than I would have imagined, kids were like, oh, yeah. And I'll say, okay, how many times a week or a month or so? And they went, oh, 3 or 5 times, or no, maybe 3 times a week. And all the while, the mom and dad's jaw is dropping as they sit beside them and hear this because they had no clue. And the reason I bring this up is unless we ask some of these questions, and of course, this is coming from a therapist's perspective, but unless we ask some of these questions, the child that this is happening to oftentimes does not know that it's abnormal because they may have been refluxing their whole life up to now or had this feeling and they didn't know it was abnormal. So until we really ask, or with older kids asking what their poop looks like. I use the Bristol stool scale to ask what their poop looks like. And they don't know sometimes what it's supposed to be or that it's not supposed to hurt when they go to the bathroom. There's sometimes red flags that we have to skip out and dig for sometimes that are not quite as obvious to see on the outside.
Those are really important for us to know. Thank you for pointing out some of those. And again, I'm sure it is very specific once you get the answers to those questions, tailoring treatment. But what does typical feeding therapy look like for anyone that's coming to you? What could they expect?
I start out with an initial evaluation, and that consists of a parent filling out a pretty detailed case history. And it doesn't matter what age they are. I have them fill out the same case history because when they come in, I go from beginning to however old they are right now to really paint a picture of how they've gotten to the point where we are at 3, 6, 10, or 15. Because oftentimes things are, like you said, the red flags are happening in infancy, early toddlerhood that no one identified. And they've just continued and persisted. And as the child gets older, we have just these behaviors of these adapting behaviors that they've developed to really deal with the problem. And so I go pretty in depth with the case history. We talk about all of those details. And then I also have the parent bring foods, some preferred foods for the child, some non-preferred foods as well. And so with the preferred foods, I'm watching them eat. I'm looking at their oral motor skills and the function with the foods that they like and enjoy and how they eat that typically. And then with the non-preferred foods that they bring, I start those observations as we're walking back to the kitchen as the child is carrying the food, because sometimes I won't even carry that non-preferred food. And so I'm looking at how they respond and their reactions once we get that food out on the table, like at what level are we coming in on of hating this food and what level of anxiety they have about this food, because that is a real issue with anxiety is closely tied to this issue of not being able to try new foods. And then at the end of that session, so my evaluations are like about an hour to an hour and a half. And then I give the parent my recommendations and suggestions at the end of that session. And then if we decide to pursue therapy, I typically see kids once a week in my office. That can vary depending on schedules and circumstances, but typically I like once a week because that allows me to establish a nice rapport and routine with the child. To see kids in my office, which is a really like home-like setting that I've done on purpose, and it has a kitchen there rather than their own kitchen table. And I know a lot of therapists like in-home settings for various reasons, and I don't disagree with that at all. But I actually like doing it in more of a neutral or a new setting because I like getting away from that kitchen table where they've had the history for maybe years and that baggage back there. And so I'm just trying to come in with a kind of a new perspective, new angle. And then, of course, quickly, though, everything that we're doing in therapy, we generalize. I'm always telling the parent what we're doing, and then they generalize that to home.
Perfect. That's amazing. Thank you so much for answering our questions. I'm sure we will get more questions, perhaps be able to bring you back on another episode. If listeners are interested, want to learn more, think they might want to come in for a consultation, where can they find you?
The best way to find me is through my website, and that is pediatricfeedingandspeech.com. There's an email link on there. My phone number, I can give you that to you. It's 703-771-2200. So a call or an email is the best way to get in touch, and I'd be happy to speak with anyone on the phone. I often speak with people on the phone first, answer any questions that they may have so they can decide if that's something they want to pursue.
Perfect. Thank you again so much for joining us today on this podcast. Thank you, everyone, for listening to the Endo Kids Podcast. If you want to learn more about us, please visit endokidsconcierge.com, and we'll see you on the next one. Have a great day. Thank you so much for joining us on the Endo Kids Podcast. We hope you're leaving with a little more knowledge and a lot more confidence. If you have questions, stories, or topics you'd love us to cover, please send them our way. We love hearing from you. And don't forget to check out our website, www.endokidsconcierge.com, for free resources, guides, and more ways to connect. You're not alone on this journey. We're here to support you and your family every step of the way. If you enjoyed this episode, don't forget to subscribe to our podcast so you never miss an update.